I'm Helen. I am a PT with Rebound. I have been a PT for almost 20 years, and I've been with Rebound for about 10 years. I'm going to talk about shoulders as well and continue on with from what Dr. McCarran talked about. Since Dr. McCarran went a little bit rogue on his talk, there is going to be a little bit of overlap with the biomechanics, but I think it'll be good. And the good thing is that our information is consistent, because that would be really embarrassing if it wasn't. I was like watching, I'm like, oh God, I really hope he doesn't say something that's like totally different than what I said. All right, I also have no disclosures or conflicts. So in terms of the shoulder anatomy, I'll kind of gloss over this because Dr. McCarran did a really nice job with this, but you know, this is the whole shoulder joint complex. You have the glenohumeral joint, the SC joint, the AC joint, and the scapulothoracic joint. But most of what we deal with, while everything contributes to it, but the majority of what we see and probably what you all see is going to come from the glenohumeral joint with scapulothoracic issues sort of contributing, as well as some AC and SC joint issues contributing, but primarily the glenohumeral joint. Dr. McCarran talked about the golf ball and a tee analogy, and that's something that's really important, and probably the most important take home for the shoulder is just the shoulder is inherently a very unstable joint, and so the control of the glenohumeral joint by the rotator cuff muscles dynamically and by the capsule and labral complex more statically is really critical with this, because it's such an unstable joint with the 6 degrees of freedom. And then in terms of the muscular anatomy, we have the periscapular muscles over on the far side of the slide, and then the rotator cuff muscles on this side of the slide. But so the periscapular muscles are what are going to really control the scapular placement, and that will contribute to the glenohumeral joint impingements and the rotator cuff issues. And I use this model a lot, which is, we do actually have a model that's not broken. We have a few, but I really like the broken one, because otherwise I feel like people can't really see in here. And so with the rotator cuff, you know, with the glenohumeral joint, with the flat, smaller socket and the large ball, the rotator cuff muscles, some of which pass underneath the acromion here. But with the periscapular musculature, which we'll talk about some strengthening on that in a little bit, if there's tightness either in the back of the glenohumeral joint, or weakness or scapular dyskinesis, then what happens is the scapula tends to tilt forward, and then the acromion pinches down on, there's a bursa that sits underneath here. The rotator cuff muscles come under here, and the long head of the bicep come under there. And that's really important, because there's a lot of pain-generating structures that are underneath the acromion, and people, and I'm sure your athletes will talk to you about this, and they'll have heard from somebody they have a bursitis, and they'll have heard from somebody they have a tendinitis, they'll hear from someone else they have a tendinosis, and it really doesn't matter, because likely they probably have all of those things going on. So like when you go into surgery and you watch, you know, somebody who has a rotator cuff issue, generally their bursa is also very inflamed. So, you know, I don't really split hairs with that, but just seeing that all the muscles on here and how they contribute to the complex. So in terms of the shoulder, the biomechanics of the shoulder joint, you need to make sure that you have appropriate flexibility. We'll talk about the posterior capsule a little bit in a minute, which that tends to be, in terms of a static structure, the biggest issue with tightness in this shoulder, at least for overhead athletes. And there also can be some flexibility issues in the musculature. Typically the pecs and the lats are the biggest culprits there. And then when you're looking at the strength issues, the periscapular muscles, as well as the rotator cuff. And it's not just their overall strength, but it's how they fire, how their endurance is when they fire. So just a quick review, it's an inherently unstable joint. It's stabilized by both the contractile musculature, the rotator cuff, and as well as the non-contractile structures. So the glenoid, so the size, the shape, the orientation of the glenoid, the capsule and the ligamentous structures. And so a lot of times this is just something that's inherent to the person, even if they haven't had an injury. Women tend to be a little bit more flexible than men. But there are some men who also have quite a bit of flexibility in their shoulders. And one of the things that you all will find working with athletes is that people tend to be very good at overhead sports if they have a lot of shoulder flexibility, which is great for a bit. But then you need to be able to balance that flexibility out with strength. And so those people who end up getting to a higher level of high school or college performance with, whether it's volleyball or throwing or swimming, oftentimes they were able to get there because they were so flexible, but then as they age and as they do these sports for longer periods of time, things will start to catch up on them, and so they just are going to always need to be a little bit stronger than the average person because they have so much flexibility. And that's just an important thing, I think, to explain, because sometimes, they come in and they're all frustrated because they've had these shoulder problems forever, and just explain, well, the reason that you were able to get to this level is because, you have this flexibility naturally, and you just need to now accompany that with some strength. The scapular position, like I explained with the model, is controlled by the periscapular muscles, and the reason that's so important, it's not just so they stand up with good posture, but it's really so they don't get the impingement. So just keeping that away from that position, and they don't get the impingement. And then managing the imbalances of musculature and capsular extensibility, as well as pore mechanics, because if those are off, that's when we end up with shoulder injuries. Again, thankfully, Dr. McCarran and I were consistent on this with the force couples of the shoulder and the rotator cuff. It allows for depression of the humeral head, and then it brings it more into the socket. So you have that fulcrum that it's pivoting on. And that is going to allow for this increase in subacromial space. So the bursa has room, so the rotator cuff tendons have room, so the long head of the bicep has room underneath there. And the other thing which complicates this is when these contractile structures in the bursa, if they get irritated, they tend to swell. If they swell, they take up more space. So now somebody who already doesn't have a whole lot of space in there because of the orientation of the joint, now they have these structures which are larger than they should be, and so then you get into this cycle where they're irritated, so they swell. So they take up more space, so they get more irritated, and then the muscles will shut off. And then they end up with even worse mechanics. And so just making sure to explain to them that they need to break that cycle first, make sure there's enough space in there to start with, and then they can start to strengthen the muscles. And the periscapular muscles, and so those are the traps and the rhomboids, the serratus anterior, all the muscles that are around the scapula. And number one, they will pull the scapula back and down and improve and increase the subacromial space. But the other thing is that we've found that when the scapula is retracted and held back in a retracted position, then the strength that you can generate from the rotator cuff is greater in that position. So if you test somebody's rotator cuff strength when they're protracted versus retracted, they will be able to generate more power when they're retracted. So if they can be back there, then A, they'll have more power, and B, they'll have fewer injuries. So looking at the two basic types of shoulder injuries that we see and that likely you will work with, there's sort of the contractile type. I have the bursa under there, which isn't really a contractile structure, but that tends to go along with the rotator cuff and the long head of the bicep injuries. And then the labral injuries, which are the non-contractile injuries, although the bicep tendon does tend to be involved with the slap injuries. And then the more aggressive labral injuries, which are more the dislocations which Dr. McCarran talked about. The anterior and inferior aspect of the capsule are more flexible generally with people, and so people do tend to have more of the anterior inferior dislocations, but there are a lot of posterior dislocations that we do see as well. And like Dr. McCarran said, it's typically more subtle, but and there are the tests to do for it, but there are some people who come in and you can feel it sublux. You don't even have to do a jerk test. They just cross their arm and then you get that big thunk posteriorly. So for I'm going to spend a little bit of time now talking about post-op rehab, and then I'm going to go back and talk about rehab to prevent injuries, to give people just a solid foundation to work with, rehab with injuries, and then rehab more specifically with a surgery. But they're all kind of the same. It's just finding when to use the certain aspects of the rehab. So it's not like there's certain exercises that you only use post-operatively. You can use all the same types of exercises with surgical and non-surgical, but I'm just going to start a little bit with, this is a very, very general post-op rehab for non-contractile structures, and then I'll talk about a very general rehab for rotator cuff repairs. But you do need to make sure you're in touch. If you are seeing athletes that had surgery, it's really important that you speak to their physician, or you get a protocol from the physician or from a PT who can get it from their physician, because even within Rebound, they're all different. And they, as you may or may not know, they get pretty particular with their rehab protocols. And so you do want to talk to the physician and find out exactly when are they okay with starting rotator cuff strengthening, when are they okay with stretching, how far are they okay with you stretching them. But in general, and this is really critical, with any sort of a non-contractile type surgery, so a capsular labral surgery, remember this is a stability surgery, and don't overstretch this, and don't stretch it too aggressively too early. So you can always stretch out something that's tight, but if you make it too loose, especially too loose too soon, then this person's going to be back in the same position which they were prior to their surgery, which is really bad. So and it's sometimes hard for these people, especially if they're people, it's different when they have like a, traumatic dislocation. Maybe they weren't super loose before, but for people who just are a little bit, have a lot of flexibility in their shoulder to start with, and then they end up having one of these surgeries, they're used to being loose, and they probably play a sport that requires a lot of flexibility, and they're going to feel tight, and that's going to feel uncomfortable for them, and it's going to bother them. But you just need to explain to them that that's okay. I kind of want them, when they're 6 months post-op, I would actually rather them not be 100% symmetrical with their flexibility, because they'll get there just with maturity of the tissue and the histological changes that will happen as the tissue matures over 9, 12, 18 months. Their flexibility will continue to improve. It needs to be good enough to be functional and to be able to at least start to do some sports. But if these people came in and they, on their other side, or what's normal for them maybe is 120 degrees of external rotation, I don't particularly want them at 120 degrees of external rotation that early. They'll get there. So just make sure you don't restore their flexibility too quickly. So in general, when somebody has a capsule or a capsular labral type surgery, they're in a sling for about 6 weeks. A lot of doctors will have them out of a sling sooner than this for this type of surgery. They're typically a little bit more consistent with the sling use with the rotator cuff repairs. But within that 6-week period, starting with just some sort of scapular mobility, so within the sling they can just be doing scapular retractions, scapular depressions. They'll often, a lot of the surgeons will have them do what they call a salute exercise, which is a salute, so like that. And so it just keeps them in this plane, and at least it gets their arm moving a little bit actively. And then they'll often allow them to externally rotate either actively, or they'll have them do it with a dowel to about 30 degrees by the side, but no external rotation up above yet. Typically at 6 weeks post-op, they'll get out of the sling, and we'll see them in PT somewhere between 4 and 6 weeks post-op. And that's when I noted there also just cautious range of motion. So stretch them, start to get them moving. But you can start the strengthening at that point. So scapular strengthening, light rotator cuff strengthening. Typically I'll start with rotator cuff isometrics. And then starting at week 12 that's when I'll start to push the range of motion more, and that's where I'll start. So if it was an anterior labral issue, I'll have them start the 90-90 stretching there. I'll often do some passive 90-90 stretching before, but I won't have them do like anything like in a door frame or anything before about 12 weeks, which is a little bit more aggressive. Something else that's really important for whether the person had surgery or if they're just out of play, is to use these early phases to address spine issues, so stiffness, which I'll talk about in a little bit, core strength, hip flexibility issues, cardio. One thing that's important for these players to know, and often just at least gives them something to do, is that this is hopefully going to be the longest time they're not playing a sport. At least during this athletic piece of their career. So use this time to, if they're a basketball player, get really good dribbling with your left hand. If they're allowed to run, getting their cardio going, or biking if they can't run. But really to not just sit around for 6 weeks and just get really out of shape, because then they're entering the rehab phase where they can be doing a lot of things with this really crummy base that they're starting from, and then they're weak, and that's just going to set them up for a much longer rehab process. So, and this is really important for you guys, because we often don't see them very much during that 0 to 6 weeks phase, but they're seeing you all the time probably. So just make sure they're not just like sitting around playing video games and getting fat, that they actually need to be working and if you can give them a really structured program, that will help them so much just long term. So with a rotator cuff repair, which again, you don't see very much. I've seen, I think, like 2 ever high school kids have rotator cuff repairs, but it happens sometimes. But the rotator cuff is a contractile structure, and this is kind of the opposite of rehab. So we typically don't see them until they're 6 weeks post-op, occasionally a little earlier if there's somebody that the physician is concerned about their flexibility because they've had a history of adhesive capsulitis or something like that. But do range of motion before strength. So I'm pretty aggressive with a range of motion here. Early passive range of motion, which we're doing hands-on with them and they're doing at home. You don't really start, you can start a little bit of scapular strengthening at about 6 weeks post-op, but you really don't start, any rotator cuff strengthening until they're 12 weeks post-op, and make sure, and we'll talk about that in a minute, that you really progress from very, very light below shoulder height rotator cuff strengthening first before you start to do anything up overhead. And it's just very important to allow for the rotator cuff to heal prior to strengthening, because these things definitely do re-tear. So this is just what I went over. Oh, and again, just using those early phases of rehab again to address the other issues that aren't the shoulder. So shoulder range of motion. The biggest issue that we find, and this is typically for non-surgical people, but it sometimes leads to them having to have like a labral or a capsular surgery. Especially for throwers, we see this a lot in baseball players, also in swimmers, is glenohumeral internal rotation deficit, or GERD, which is internal rotation deficiency up here. So the one thing that they've found, so it used to be when we first started talking about this probably 10 or 15 years ago, that it was just all about internal rotation and you comparing the right or this dominant side or the throwing side versus a non-throwing side, and making sure that they're within about 15 degrees of one another. But what we found is that sometimes, especially people who started throwing at a very young age, will get some torsion in their bone, and so they'll just be lacking internal rotation just from a bony standpoint. And so you want to look at their total arc of motion. So you do still want, you want both shoulders to be within about 15 to 20 degrees in terms of symmetry with their range of motion. But if on one side they have 130 degrees of external rotation and 60 degrees of internal rotation, then what was that, 190? So they have 190 total on the one side. If they have about 180, 190 on the other side, that's kind of okay. But it's the people who have 110 degrees of external rotation, but then like 20 degrees of internal rotation compared to something that's very different on the other side. So do make sure that you are comparing both the total arc of motion, both the external and the internal rotation. And it's important that you check this and you stretch this with their scapula blocked. So most of you have probably seen and done and had your athletes do the sleeper stretch, which is this guy right here. And the reason that he's lying on his side is because it blocks the lateral edge of the scapula. If you just have somebody stretching into internal rotation like this, oftentimes what they'll do is they'll just be stretching their whole scapular area, so you're really not getting a lot of stretch at the posterior part of the capsule. So if they lie on their side, and you'll see a big difference. If you look at their internal rotation when they're even just lying on their back, they'll often look okay. And then if you have them onto their side, you'll notice that it's really tight once their scapula is blocked. So this is a good, I think this is probably the most effective stretch for people to do on their own, is the sleeper stretch here on their side. There he's doing it upright, which also works, but it's a little bit more practical, so they can do it just like when they're at the field, just standing, and he's blocking the side of his scapula just on that post. I think the sideline one's a little bit more effective, but they both work. Something else to address the posterior capsule. The research for this is pretty gray, but anecdotally, I think it seems to work for my patients at least a couple times, is any sort of A-stim or grastin to the posterior capsule, so scraping. That's if somebody's really, really tight back there. And so just doing a little bit of the scraping first and then have them do the sleeper stretch. I don't go too crazy with it, but I'll often do it a few times, especially if they come in and they're really, really tight. I mean, some people come in and they have like 10 degrees of internal rotation, and it's amazing they were able to throw at all without pain. Other areas of tightness to look at in the shoulder are just their chest and their pec tightness, and then their lat tightness. I'm not a huge fan of the doorway stretch for the pecs or for external rotation, unless it's somebody who had surgery who just really needs some cueing to keep their arm up there. But I don't really like when you are pressing all the way in forward, because it tends to really aggravate people's bicep tendon, which is a really big pain generator for the shoulder. So I prefer attach the microphone, like a wall slide here, and then just having them actively retract their scapulas, bring their arms back, and then trying to keep their elbows and their hands on the wall. I think that is a little bit more effective, and it's less irritable on the long head of the bicep. So the spine, and Mike touched on this a little bit when he was talking about the hips and the hip tightness in the lumbar spine, but the same thing happens with the thoracic spine and the shoulder. Is if somebody is really tight in their thoracic spine, then that's going to increase the demand on the shoulder. So if they really have very limited thoracic spine extension, then they have to, if they're going to throw or do anything up here, then they're going to need more external rotation in the shoulder, which then tends to set people up for more anterior labrum and bicep tendon issues. So, and this is again something that somebody can do if they've just had surgery, or if they're not, if they're really not able to do a lot of shoulder exercises, they can keep the one hand here. An extension stretch over a foam roll works really well. Also, thoracic rotation and lumbar rotation. First of all, it will also, if you're really tight, it's going to increase the demand on the other parts of your body, but you also are going to be able to generate a lot less force. And so just from a performance standpoint, it's really important to make sure that your players are maintaining good rotation in their spine, so they can use their whole body to be throwing, and they're not just throwing with their arm. Range of motion of the hips is also critical for the shoulder. This is something that's been coming up a lot more lately with shoulder and elbow injuries, for UCL injuries and other types of shoulder injuries for throwers, is that we've found that throughout a season, a baseball season, players will start, especially pitchers, start losing external rotation in their hip as the season goes. It just starts to get tighter and tighter. And as you lose the rotation in your hip, then that increases the demand on your lumbar spine. It increases the demand on your glenohumeral external rotation and also the elbow valgus force. So, and then also, which players seem to care about more of their performance, it will decrease their power as well. So just making sure that the players have good hip flexibility, so hip extension, hip rotation primarily. Because those are the ones that tend to get lost. And then your core, so your legs, your glutes, your periscapular muscles, and the rotator cuff. So with strengthening, obviously, core is a big thing now. And this is something that can be done, again, very, very early on in the rehab. And you couldn't be doing, the top plank one early on if you had a shoulder surgery, but you can be doing bridges, you can be doing sidestepping. We'll show you pictures of those in a second. But there's all sorts of core exercises which can be done and which should be done, because the stronger you are in your core, again, the better, you're going to be able to perform better, but you're also going to be much less vulnerable for other injuries. Jeff's going to come up and start to demonstrate some things. So I didn't bring a med ball over, but so these are just a couple just core strengthening exercises which we use just outside of just the typical planks, bridges, sidestepping, and things like that. So with a medicine ball, if you just get your throwers to more go through the throwing motion and just stepping up onto things. And so if somebody just had surgery, they're not going to be able to hold, he's holding a little ball, but in the picture he's holding the medicine ball. They're not going to be able to hold a big one, but even just starting with just throwing and hitting motions. And then, when you're doing the core strengthening, you want to make sure that you're not just working in the sagittal plane, and that you're doing things in the transverse and in the coronal plane just to work all different aspects of your core. Another core muscle, or really scapular muscle, I guess, that I think is often forgotten about but very important is your serratus anterior. This is a great exercise. We show that really quick. That's like that. I know you're in fancy clothes. All right, well, like in a plank, reach over, and so making sure that you're stabilizing. You can stand up and look at Jeff. But these are also great exercises. So more of the basic scapular exercises, which you can start much earlier on. I always start low because people tend to have poor mechanics when they're first starting. So making sure you're not doing anything at or above shoulder height, because they end up impinging. So middle and lower trap exercises with the TheraBand, and these are things that they can do in the training room with you or out of the field. I's, T's, and Y's on a ball or on the floor. Notice the weight. So I noticed that athletes come in and they tend to be using really, really big weights, which either they're not, their mechanics look terrible when they're using them, or they're just sort of recruiting all these other huge muscles and not the muscles that really control the shoulder positioning. Once they can start with the rotator cuff muscles, so you saw in Dr. McCarron's pictures, the rotator cuff muscles, the muscle bellies are tiny. So even under the best of circumstances with high-level pitchers, throwers, overhead athletes, you'll notice that people who are throwers at a very high level, they don't have huge arms. And so these are very small muscles. I'll see people doing like sideline external rotation with like a 10-pound weight. You really can't use your rotator cuff if you're using a 10-pound weight on your side. You're using like everything else, and not anything that's helping the mechanics of your shoulder. So making sure that you're starting with very, very light bands. I mean, he has a green band. I usually start with yellow or red, and I often will max out at the red. And if they're doing it correctly, it will really, really fatigue quickly after about 12 or 15 repetitions with really light bands. Notice that he has a towel roll here. If you put a little bit of something just to give you some space under there, that just allows for a little bit more space under in the subacromial area. And so I encourage you, to have a towel roll or some sort of pad under here when they're doing it, and then also making sure that you stay in a really neutral range. So I'll have them start at neutral and go out to like 45. So don't have them go through this huge range, because again, as they externally rotate way out here, they end up exposing the long head of the bicep, and then that ends up getting really irritated. And they'll find that they'll fatigue more too if they're in this small, close-in range. So both upright and side-lying external rotation are super basic, but I think are probably the most important exercises to start with for any rotator cuff strengthening. Once they have a good base, then moving to more of like the 90-90 external rotation and internal rotation. If they have an elbow issue, then coming up there and doing the wrist exercises up in that position. Jeff will demonstrate this one. And then you start to get a little bit more complicated once, you know, and so at this point, hopefully their core is nice and strong, and you're pulling their glutes into it, their shoulders into it. And then if they are throwers, you know, getting them with a ball in their hand. This room it's not tall enough for Jeff, but for most people. So starting throwing here before you start doing other throwing, longer distances, ball drops. And then, especially for pitchers, just moving on to their pitching positions. I'm not going to spend too much time on this because Jeff's going to talk a lot about all this stuff, but just starting to do more sport-specific activities. But this is all after you've established they have good rotator cuff strength, they have good scapular strength, their spine is flexible, their hips are flexible, their glutes are strong. So in summary, number one, I think most important thing for these issues, because it's something that you can't ever go back on, is don't overstretch the non-contractile surgeries. Don't stretch them too early. Number two, rotator cuff muscles are very small, but they're critical, so don't try to strengthen the rotator cuff with really big weights because it's not going to work. Wait on weight bearing and anything above shoulder height until they have really good scapular control and good rotator cuff strength down low. Use off time and early rehab time to get the athlete ready for return to sport. They will do much better, much more quickly once they get to that point, and they'll end up with much fewer problems. And just that shoulder health is not just about the shoulder, just make sure you're addressing their core, their hips, and everything else. Any questions? Yeah.
When you're doing the rotator cuff exercises, you notice you're doing that small range, more fatigue. Do you see that's more effective than doing the gross motion?
I do think I think it's more effective, and they're able to do it, especially for people who have tendonitis and things like that, or post-op, they're able to do it without pain. You do at some point need to move to larger ranges just because they're more functional, but I would, at the early stages, yes, I think it's much more effective, and it's actually more tiring because you can't use the momentum of those first, 90 degrees within here. So yeah.
Okay, because I've noticed like you go off patients that will do it and they don't control back and something like that.
Exactly, yeah.
I guess you're right, poor mechanics, something like that, and since they are smaller vessels, it seems like that would be more of a fatigue strength.
It's definitely much more fatiguing. Yeah, if you try it both ways, it's way harder to do it in this small range.
Thank you.
Any other questions? Thanks, Jeff.